webinar titled Sexuality in Long-Term Care, Ethical and Practical Issues. This is the second installment in the fourth Mental Health and Aging Training Initiative series of webinars initiated by the Geriatric Mental Health Partnership. The Geriatric Mental Health Partnership is an informal, voluntary group of diverse stakeholders which focuses on geriatric mental and behavioral health care in the Commonwealth of Virginia. This webinar will focus on sexuality in the aging adult and address ethical matters related to consent in those with and without dementia. Questions and discussion will follow as long as time permits. This event is made possible through a grant through the Virginia Center on Aging's Geriatric Training and Education Initiative and is supported by Riverside Center for Excellence in Aging and Lifelong Health, the Virginia Geriatric Mental Health Partnership, ECU's Department of Gerontology, and World Events Forum. Today we're fortunate to have two presenters. First, Dr. Andrew Heck. He is a licensed clinical psychologist and clinical director at Piedmont Geriatric Hospital in Burkeville, Virginia. Dr. Heck is board certified in both clinical psychology and geropsychology. Courtney Petley is a licensed clinical social worker and director of psychosocial rehabilitation department at Piedmont Geriatric Hospital with 11 years of experience working with older adults. I'll refer you to the webinar hub for presenter bios, series summary, and additional details and contact information. I'd like to thank the Geriatric Mental Health Partnership Planning Committee for their efforts to secure topics as well as presenters. And as always, I'd like to thank Nico Stankulescu, our platform facilitator with World Events Forum. She puts in countless hours behind the scenes to bring these educational opportunities to you. And I'm Ann Welliford, your moderator, Chair of the Department of Gerontology in the School of Allied Health Professions at Virginia Commonwealth University, and I'm also a member of the Geriatric Mental Health Partnership. I'd like to share just a couple of housekeeping items before we begin. I hope you've all taken advantage of checking out the slides and downloading them for note-taking and sharing. They're on the webinar hub. Please make a point to complete the survey following the webinar. You see the instructions here. This survey is from our funder, and it enables us to provide these continuing education opportunities for you for free. This is also how you will receive your certificate of attendance. We will be holding several interactive polls during the session, so please stay poised and ready with your mouse in hand so you can participate throughout. Throughout the webinar, you will also have an opportunity to post questions for our question and answer session at the end of our series. So please take the opportunity to do that. So at this point, I'm going to turn the microphone over to Andrew Heck and Courtney Petley.
All right, thank you, Dr. Welliford. We're delighted to be here, and we want to thank everybody for joining us for a discussion about this very important topic. Let me put this in presentation. Okay. So today we're going to discuss sexuality and long-term care, and I thought we could lead with a brief mention of sex and dementia on trial is how I've got that. And everybody that I've talked to that knew the webinar was coming up has mentioned to me, did you see the trial? Did you see the trial? And there is, for those of you who haven't heard, there has been a trial going on in Iowa. There's a state senator by the name of Henry Ray Hans, and he had a wife by the name of Donna Lou Young. They married after age 70. She was diagnosed with Alzheimer's disease at age 75 back in 2010. She moved into a nursing home in 2014. There was concern on the part of Donna's daughters that Henry was engaging in sex with his wife, with their mother. And as soon as the mother passed in 2014, the children pressed charges against Henry for having sex with somebody who couldn't give consent, according to them. And it just so happens, timing-wise, that the verdict came down yesterday that he is not guilty. But the reason he's not guilty is because they couldn't prove that he actually engaged in sexual relations with her. So we thought that perhaps this trial was going to be some sort of referendum on capacity issues and sexuality, and in the end, it turned out that the issue that he couldn't be proven to have had sex with her resulted in a not guilty verdict. But it did draw an awful lot of attention to this issue, and many, many more people have dealt with this issue privately and certainly not in the news. But we're thrilled to be talking about it today because it needs a lot more dialogue than it's gotten up to this point. I'm trying to
just click
change.
one more. Just click one more time on it. Perfect. That's it.
There we go. Thank you. As far as learning objectives today, we want to be able to define sexuality first of all and describe what is considered to be sexual expression, specifically in the context of older adults. We really want folks to understand the lifelong nature of need for sexuality and intimacy. We want folks to foster ways of healthy sexual expression on the part of residents in long-term care settings, and we want to talk briefly about managing challenging behaviors surrounding sex in a long-term care setting. The reason I say we're going to talk about that a little bit is because that is a topic in and of itself that could be discussed for days on end, but we're going to get to as much of that today as we can. So at this point, I'm going to turn it over to Courtney to talk about sexuality and person-centered care.
All right, thank you very much. So we're going to start out with some kind of larger concepts and then move into more detailed information just to make sure that we're all on the same page and we're all kind of talking about the same thing. So when we talk about person-centered care, we want to make sure that we are addressing the whole person, and as we will talk more about today, recognizing that the whole person does include an individual's sexuality. Person-centered care is dependent on a team approach and including the patient and their family in the team, supporting and building trusting relationships with that patient, getting to know the person, and finally making sure that appropriate care is readily accessible and that we're decreasing any barriers to that appropriate care. When we talk about sexuality, we want to keep in mind that that is an aspect of being human throughout the lifespan. So it doesn't stop once we reach a certain age. Looking at the image on your screen, the items in the green sections help define our sexuality, and then the items in the white boxes on the periphery are the behavioral ways that we express and experience our sexuality. And we want to keep in mind also that our sexuality is influenced by the interaction of many different factors, including biological, psychological, social and legal factors, as well as political and religious or spiritual factors. And finally, laying the groundwork with our understanding of intimacy and recognizing that intimacy encompasses all of the things on this slide, and sexuality is one dimension of intimacy. What we're going to learn in our discussion today is that older adults' perceptions of their own sexuality change with age, and so aspects of intimacy other than physical ones may become more important. So what we've also seen is that studies indicate that the most frequent sexual expression among nursing home residents is manifested through maintenance of their physical attractiveness. So intimacy is going to look different for different individuals based on their individual needs. So how does our sexuality and our needs for intimacy relate to person-centered care? What we need to recognize is that our sexuality is an important part of our identity and our sense of self. It's part of what makes us who we are. It's part of our life experience, and it's unique for each individual. So in providing person-centered care, we it's our responsibility to support the unique individuality of each patient or resident, respecting and supporting their personhood, and that includes their sexuality. And I also want to introduce a special concept today. We talk a lot about person-centered care, but I want us to start thinking about the idea of relationship-centered care, which is an inclusive approach that sees the person within the context of important and significant relationships in their lives. So given this perspective, we have a responsibility as professional care providers to support our residents in the maintenance and development of positive supportive relationships. And with that, I'm going to turn it over to Dr. Heck to lay the groundwork for some ethical considerations.
Thank you. You know, what this issue typically comes down to is an issue of autonomy versus beneficence. And like so many other issues we run into in the area of care of older adults, it ends up being competing ethical principles. One, we want to preserve an individual's autonomy, or that obligation to make sure that their right to live as they choose is important. And then beneficence being, as you can see on the slide, the obligation to protect residents from harm or exploitation or abuse. And it's very difficult on a very practical level to balance autonomy and beneficence perfectly. We find ourselves struggling between should I intervene or should I not intervene, which would be best for this individual. And for caregivers especially, it can be a daily struggle, balancing autonomy versus beneficence. So in the context of sexuality, our goal remains to provide that balance between autonomy and beneficence. It's not that autonomy always completely wins out or that beneficence always completely wins out. It truly is a balance between the two to arrive at what we sometimes call an ethically acceptable solution. So here's an example of what could happen if we overvalue autonomy. And this is just a for instance. That could lead to an unsafe behavior. It could lead to some sort of harm or really a morally questionable environment. The example that I ran into, a very extreme example to be sure, but in Denmark, a Copenhagen nursing home broadcasts pornography every Saturday night, which in terms of Western culture, that would be pretty outrageous. And staff will even order prostitutes at the resident's request, as prostitution is legal. So that is essentially serving the resident's autonomy, probably over other ethical principles. Now, if we give an example of overvaluing beneficence, this could lead to what I found in the literature as a quote of overzealous prohibition of appropriate sexual behavior. And this actually was an example I put in before we ran into the information of the current trial that I just spoke about before. But in Ohio, a man had sued for the right to spend nights with his mentally incompetent wife in a nursing facility. This is back in 1999. And the facility denied his request. The court ruled against his request, and the facility's rationale for doing so, upheld by the court, was the complex legal environment in which we exist. So in essence, this man could not spend the night with his wife because she lacked capacity to make that decision, presumably. And also in Great Britain, similarly, 2007 saw the advent of the new Mental Capacity Act. Essentially what this said was that if you engage in sexual relationship with somebody who has a diagnosis of dementia, you could risk prosecution. And there is no exclusion for marriage. So this sets a legal precedent in a lot of different ways that the world has set up and taken notice of.
Okay. So we've come to our first poll for today's webinar. And we're getting ready to start talking about what sexuality looks like in older adults. So our question for the audience is, if there is no physical disability, people may remain interested in sex well into their 80s and 90s. And is this true or false?
Okay, folks, remember I said keep your clickers ready. This is your time to participate in the poll. Many of you have done this before, so please take your opportunity now to choose true or false. Wow! We have a resounding winner. 99% responded true and 1% responded false.
Okay, very good. So what we know is that as we age, there are a number of common health issues which can impact sexual functioning. Physical, mental, and emotional health is strongly associated with, is more strongly associated with many sexual problems than age alone. A study in 2013 of over 22,000 individuals, 55 years and older, found that 55% of men and 45% of women report being sexually active. And those who were sexually active were also engaging in lots of other activities such as regular exercise, participating in other physical and social activities, so remaining actively involved in the community. They also reported having good quality of life, good social support, and fewer physical health problems. So the bottom line is that people who are in good physical health are more likely to have an intimate relationship and more likely to be sexually active with a partner. And there was really a landmark study that was published in the New England Journal of Medicine in 2007. No study like this had been performed before in the past. What researchers did was interview 3,005 U.S. adults between the ages of 57 and 85 between 2005 and 2006, and there was a pretty even split among participants between men and women. Interviews were conducted in participants' homes and included a complete marital and cohabiting history, including sexual partnerships in the past 5 years. And the first major outcome of this study was that the likelihood of being sexually active declined with age. It was lower among women than men. And again, it was being sexually active was positively associated with self-reported physical health. The second major outcome of this study was that sexual behavior in younger adulthood is a good predictor of sexual behavior as one ages, even for those with dementia, which I found pretty interesting, that that sexual behavior did not change significantly as we age. This next slide shows the frequency of masturbation among this older adult group. And the reason that I think it's important to pull this particular information out is that despite the fact that this can be a very distressing behavior from a staff perspective in a long-term care setting, masturbation is fairly prevalent among older adults, both men and women. And therefore, we need to expect that our residents are engaging in this activity as well and be prepared to manage it in a person-centered way and not perceive it as necessarily inappropriate. Now, there was another study in 2003 that explored older adults' views about sex and sexuality through a quality of life measure. And some of the important results from this study were that sexuality in older adults can take the form of affection, romance, companionship, personal grooming, touch, or the need to feel attractive or masculine or feminine. So that's a pretty wide range of types of sexual expression. That's a pretty wide range. The other thing that I thought was notable from this study, physical intimacy through cuddling and touching becomes more central to well-being when intercourse is no longer possible. And only when barriers to sexual activity were seen as so insurmountable to be completely prohibitive did sex assume no importance at all, regardless of age. So overall, sexuality and intimacy remains very important to our quality of life and well-being well into our later decades. And finally, this study from 2011 provided some interesting statistics as well. So 85% of individuals over 50 reported a decrease in frequency of sexual activity, but 61% of those folks said that sex was more fulfilling than in younger years. So that's encouraging. And 42% of the participants described themselves as sexually active at least once a week. I did want to spend a little bit of time just talking about the LGBT population among our elders. When we think about that concept of relationship-centered care that I mentioned earlier, I think this is very important. LGBT individuals are twice as likely to live alone as heterosexual individuals, and they are more than 4 times as likely to have no children. So what this means is that they have limited social support networks, making the relationships that they are able to develop and maintain in the long-term care setting even more important. And it's just very important to recognize that we cannot assume that all of our residents are heterosexual. We really need to be aware of the sexual minorities in our workplace and long-term care settings and be sensitive and empathetic to their needs. So as we've seen, there are many benefits of intimacy and sexuality, particularly those identified on the slide, that those engaged in intimate relationships exhibit greater independence, better cognitive functioning, longer life expectancy, and a decreased risk of chronic health problems. And casual relationships do not provide those same benefits. Personal relationships have been found to be the single strongest predictor of quality of life among older adults based on one study. So that tells me that we have a responsibility to foster the maintenance and formation of meaningful relationships among our residents. And that includes both romantic and platonic relationships. And addressing residents' needs for intimacy and sexual expression may improve quality of life and prevent future difficult-to-manage sexual behavior. So that's kind of a snapshot of sexuality and sexual behavior among healthy older adults. When we look at that group of folks who have been diagnosed with a dementia, there are some changes that we see. And sexual behavior in dementia is probably the most difficult to manage from a professional caregiver perspective. Even though agitation and aggression related to dementia is much more frequently observed. I think it's also interesting to note that apathy and decline in interest among individuals with dementia is more common than inappropriate sexual behaviors or hypersexuality. And again, I think that might be surprising to some of us because it is such a stressful and difficult behavior to address and manage. What we know is that sexuality is frequently noted in men, more frequently noted in men. It's more often perceived as explicitly sexual in men with dementia and long-term care, whereas women are more often perceived as vulnerable and in need of protection, or just being kind of flirty. So it's not perceived as such a negative behavior in women. And sexual behavior is more often seen as a challenging behavior rather than a need for comfort or intimacy or some other unmet need. And we need to keep in mind that that behavior may have an entirely different meaning to the resident. Inappropriate sexual behavior in dementia is observed throughout the spectrum of cognitive impairment from mild to severe. There's a pretty wide range of prevalence when you look at the literature, as you can see from the numbers there on the slide. A review of the literature also reflects a higher prevalence of inappropriate sexual behavior in dementia in long-term care settings. But I wonder if this could be due to underreporting by family members or in-home caregivers, maybe because of embarrassment or stigma, or it could be related to increased rates of loneliness and decreased access to sexual partners in the long-term care facilities. This slide kind of outlines some of the changes to sexuality and sexual behavior that might be seen in an individual with dementia. So there's a number of them listed there. One study that I came across identified two different types of sexual behaviors. They classified them in two different ways. The first category was defined as intimacy-seeking behaviors. So those would be things like kissing or hugging, masturbation. And those behaviors tended to be more associated with dementia of the Alzheimer's type, whereas the other category was classified as disinhibited behaviors. And those were defined as sexual contact that occurs in the wrong place. So for example, removing clothing, exposing oneself, making lewd remarks in public places or to inappropriate people. And those types of disinhibited behaviors were more associated with other types of dementia, such as Pick's disease or vascular dementia. And I think it's important to highlight these two categories because the type of inappropriate sexual behavior that we're observing can have implications for how we manage and treat it and intervene with that person. So there are a number of underlying causes for inappropriate sexual behavior in dementia, and those can be biological or psychological. And it's important to be able to assess those to figure out, again, what's going to be the best way to intervene for this individual. So kind of the three primary biological causes of those behaviors are some type of brain injury. Damage to different areas of the brain can lead to changes in sexual behavior. For example, the frontal and temporal lobes, which are the main areas responsible for the libido. And you might see changes like that, again, in Pick's disease or Lewy body dementia. And then the hormones and neurotransmitters found in the hypothalamus also have an impact on sexual behavior. Delirium is a very important thing we need to look out for. Cognitive changes, acute cognitive changes and behavioral changes that can be due to a medical problem, such as a metabolic disturbance, maybe elevated or too low blood sugar, an infection, a urinary tract infection, or a medication can lead to sexual behaviors. And then there are some psychiatric disorders also, for example, the manic phase of bipolar disorder, substance abuse, the disinhibition of Tourette syndrome, for example. And then some of the psychological causes of inappropriate sexual behavior and dementia can be loss of self-esteem and self-image that comes with the progression of a dementia. It can lead to efforts to regain it through sexual expression. Lack of personal touch and intimacy is common in the long-term setting, so that could lead some to act out a strong need for connection and touch. I think it's also important to think about how we as staff might contribute to confusion about others' identity or misinterpretation of intentions. Sometimes if residents are attractive or particularly well-liked, staff might do things like call the person by affectionate names or ask them for a kiss or give them a hug without permission. And that can be demeaning for the resident, but also for those with cognitive impairment, those kinds of behaviors can send mixed messages about the staff person's role and blur boundaries. So we need to be really mindful of the messages that we're sending when we're interacting with folks. Also, if we're not being direct and very clear when providing intimate personal care, that can be very confusing, especially nursing staff who assist with ADL care. Dressing and bathing are very intimate tasks, and so that unless we are being very clear in stating what we are getting ready to do and reinforcing our role as a professional care provider, that could be confusing to the resident. And boredom can also lead to sexual behavior. So now that we kind of know some of those underlying causes and what to look for, what might be causing some sexual behaviors that we're observing, we need to look at some of the ways that we can try to manage those. Today most of the management strategies we're going to talk about are going to be more environmental modifications. So the first thing that we need to do is really to be aware of our own sexuality, our own beliefs and values and morals, and whether or not we're carrying those with us in our interactions with our residents. When we deny the importance of sexuality and sexual health in older adults, it really can lead to attitudes among staff that sex is inappropriate, that it's laughable or shameful. You know, older adults tend to remind us of our grandparents or our parents or older loved ones, and this can make it really difficult to consider the idea that they might be sexually active or intimate. So as staff in long-term care facilities, we have a duty to create an environment that's going to help residents fulfill their needs and desires while also maintaining their dignity and not harming others. And we need to also keep in mind that the stereotypes and the attitudes that are present in staff are going to have an impact on patients. There was a Finnish study cited in a journal that found that older adults really do internalize the societal stereotypes and beliefs. Over half the people in the study did not think it was, quote, proper for older adults to be sexually active. So we need to be very careful of the culture that we are developing in our long-term care setting as well. Again, being intentional in our interactions with older adults, with our residents, being clear and conveying the professional nature of your relationship can decrease the likelihood that a resident will mistake your intentions and respond to you in a sexual way. And I cannot emphasize enough the importance of having a written policy in your facility about sexual expression among residents. The purpose of that policy is to ensure that the environment is tolerant and respects and supports residents, including those with dementia, to safely meet their sexual needs. It also codifies facility values and beliefs on sexuality and sexual behavior and ensures that all situations are handled consistently. And a really good policy is going to address training, staff training, ways to address behaviors and respond to behaviors to make sure everybody is doing it consistently. So there are really 5 most common barriers to sexual expression in long-term care settings. And so what you can see on the slide in front of you is the first 3 of those. And some of the things that you can do as a facility to resolve those barriers. Lack of privacy is the #1 reason cited by staff and residents for lack of sexual activity in nursing homes. And pet visits and animal-assisted therapy can be very effective in decreasing loneliness. Making beauty shops and cosmetic services can go a long way as well. And then the last two barriers are attitudes of staff and attitudes of family. Attitudes of staff really can kind of make or break sexual expression in long-term care. And a 1999 study of staff attitudes towards institutionalized elderly identified 3 categories of the type of sexual incident and the resulting reactions from staff. And the first of those was loving and caring interactions. So if an older adult or a resident was engaging in what was described as a loving and caring activity, it was met with acceptance and support by the staff. If their behavior was perceived as romantic, it would be met with mixed reactions, including humor. And then erotic type behavior is often met with hostility, anger, or disgust. And oftentimes, some of the more general reactions to any type of sexual behavior on the part of long-term care staff can be confusion, embarrassment, not really knowing how to respond, so a feeling of helplessness, or rejection, so not wanting to interact with that particular resident. The other thing that we can do that's very, very helpful is make sure we get a thorough medical and sexual history on our residents when they come to our facilities. Look for any of those medical conditions known to influence sexuality. Keep an eye on new or sudden onset sexual behavior, as that may be a sign of delirium. And then explore what some of that individual's values are. What are their relationship patterns? How do they prefer to express affection and love for others? When we can incorporate this information into our assessment and then into our care plans, it can go a long way in helping staff know how to respond to a particular patient's behaviors. Okay. We need to keep in mind that all behavior is purposeful, and it's our job as the professional caregivers to determine the reason for the behavior and then address any unmet needs. So it can be really difficult sometimes to differentiate between inappropriate sexual behavior and dementia and appropriate sexual expression. So 2 key factors to try to keep in mind when we're trying to make that call is to consider the safety of the individuals involved and whether the behavior is causing distress to any parties. And the questions on your slide can be helpful as well. We want to keep in mind that behaviors can be a case of mistaken identity or misinterpretation of environmental cues, or simply the need for human contact. So we want to be observant of cues that may reflect unmet intimacy needs, such as increased use of touch by the resident. Staff communication is going to be really important in responding in a person-centered way to sexual behavior and sexual expression in our residents. We need to reduce the taboo of discussing sexuality, and staff meetings should include reports of sexual behavior so we can share interventions, what has worked for a particular staff member with a particular resident, educating everybody on each shift about sexual behavior among residents so they can know what to expect, and so everybody can be responding in the same way. We want to encourage them to report unwelcome sexual behavior from residents to another staff person immediately. We don't want staff to have any sense of guilt that they've done something wrong to cause this behavior. We need to make sure we're communicating so we can address it appropriately. And a logbook can sometimes be a very helpful communication tool to meet those goals. Again, family involvement is very, very important. and we need to keep in mind that family members may be, they may be very upset by the reports of sexual expression or inappropriate sexual behavior by their loved one. But we need to keep in mind what they may be feeling. They may be afraid for their safety, their loved one's safety. If their loved one is the person engaging in the inappropriate behavior, they may be angry or ashamed. And they may have fear that their loved one might be isolated, victimized themselves, or evicted as a result of the sexually inappropriate behaviors. So what we know is that families are often a lot better able to cope with those behaviors in their loved ones when they understand the needs of older adults for love and intimacy, and when they are able to participate in problem solving and developing strategies to address the behaviors and help their loved one get their sexual and intimacy needs met, while also making sure that everyone's rights and safety is maintained. And finally, there is really limited research on the effectiveness of medications on inappropriate sexual behavior and dementia. And pharmacologic interventions really should only be attempted when other behavioral interventions have failed. There was one study that compared non-pharm and pharmacological interventions. They paired medications only with a team approach plus medications, and those residents that had the team approach had a 44% reduction in behaviors, whereas the control group who got medications only received twice as many med changes and side effects. So whenever possible, we want to try behavioral and environmental modifications first. And intimate relationships between residents can also be very difficult to manage. In most cases, those two residents already have a stable relationship before that sexual advance is made. And so, for example, they often sat and talked together, had meals together, sought each other out during activities. The rights of both parties need to be respected when we are considering how to appropriately intervene in those situations. And an interdisciplinary team meeting is strongly recommended to develop a strategy to support those individuals and make sure everybody's safe. The questions that you see on this slide can be very helpful when identifying the problem with intimate relationships between residents and what some possible interventions might be. I really like the question, the two questions: are there any risks resulting from the behavior, and who are those risks for? And is the behavior causing distress or conflict of values for anyone, and if so, why? Being able to weigh the benefits against the risks can be very helpful. And with that, we're getting ready to go into our section on capacity issues. So we have a poll here. If families object to their relative having sexual activity, it is the duty of the management to prevent such activity. And do you think this is true or false?
Okay, it's your turn again to participate in our second poll. So take the opportunity now. Let us know what you think. Interesting. I always like these questions that, you want to dig into this a little further and see how people come up with these responses. Experience, I think, is such an important factor here. Okay, so we have 15% who say true and 85% who say false.
That is interesting, and I think in most cases we have to back away from such a blunt question and say, well, it depends. I know mental health professionals are great about saying it depends, but it is true. Most of this is very contextual. So one of the important contextual factors we're going to talk about is whether or not an individual has the capacity to decide to enter into a sexual relationship. Is it as simple as choosing, well, what flavor ice cream do I want to have for dessert? The answer to that question is no, it's not that simple. It is a very complex, layered issue. Sexuality in general, not just in older adults, is a complex, layered issue, and then you add issues that we might be dealing with on top of that that are due to age or medical conditions or institutional policy. It becomes very complicated very quickly. There is a tension between protecting the vulnerable residents from exploitation and harm versus ensuring that their right to express their sexuality and experience sexuality safely is assured. The assumption is that people should have the freedom and the right to enjoy sexual expression as long as it is not at somebody else's expense. Now, the level of risk has to be weighed against the significant risks that negation of the autonomy presents to emotional and mental well-being. And by that, I mean there has to be enough risk. There has to be enough risk involved in a sexual relationship or a sexual encounter to justify taking that right away from the individual to make that decision. And I think when thinking about this in the context of it to a clinical decision. It's really very, very difficult just to say, well, medically speaking, you can't make that decision because it is such a touchy issue. So we want to bear in mind that even though we want to take a rational clinical approach to this sometimes, there is an emotional component that can't be ignored and sometimes can't even be explained. So this is a model of capacity, and it looks more involved than it actually is. But I want to go through the different components of it to explain how somebody might arrive at whether or not a person can make a decision about whether to engage in a sexual relationship. Now, if you look on your left, you see three boxes: cognition, specific task ability, and context. These are the three components, three components that we look for first to see if a person has capacity. Cognition is fairly self-explanatory. Is the person's memory, is the person's language skill, is the person's ability to attend, sustain attention, to focus their attention, etc. Are those abilities intact? And if they're not, at what level are they intact? Because it's not an all or nothing situation. So we look at different domains of cognitive functioning to get a picture of where they are. Second of all, we want to consider the specific task ability. Now, if we were looking at financial decision making, we would want to make sure that the person could do math, that the person knows how to use a checkbook, that the person understands the concept of maybe interest, depending on the financial decision they're making. This is a little different in sexuality because there's not a lot to know intellectually about sexual behavior. It is largely a visceral action. I mean, most folks know what they're doing in terms of sexuality, in terms of what biology is pushing them to want to do. So we don't usually do a lot of examination of a person's knowledge or ability surrounding sex. But the next box that you see, context, is very, very important because their own relationship situation, the setting that they're in, the capability of the environment to accommodate, all of those things do play into whether or not an individual can make this decision. So once we have all of that information, we compare all of that against a set of standards. And you'll see those in the middle: the choice, understanding, appreciation, and reason. And I'll go to the next slide real quickly here. This set of standards were put forward by a couple of authors by the name of Bristow and Applebaum, and it's a pretty universal conceptualization of decision-making capacity. So their first step is to say, okay, the individual, in order to be considered capable of making a decision, they have to be able to communicate a choice. They don't have to do it verbally. They can shake their head, or they can give you some sort of other indication that they have a preference. That's the lowest level of decision-making ability. The next level that they have to be able to get to is a level of understanding all the relevant information involved in a decision. Understanding involves the ability to get the information, to retain the information, and in some cases to be able to reproduce the information. So people with memory disorders sometimes have trouble with this level of decision-making capacity because if you can't retain information, it's hard to understand the information. Now, it's not that there's a high standard of understanding the information in some decisions. There may not be a lot to understand. It depends on the decision that is being made. So in terms of sexual decision making, it's possible that even folks with moderate levels of dementia, for instance, can still understand enough to be considered to meet this standard number 2. The third standard is a standard we call appreciation. And that is, does the person really appreciate what this means for themselves, what the consequences of this decision could be, what it means for somebody else who's involved, the other partner or other people around. The ability to apply what they know is really what this standard is about, the appreciation. And then the fourth standard, the highest level of ability this person needs to show to be considered capable, is the ability to arrive at a decision based on reason or logic. What we find is, for example, some people who have psychotic disorders or who have lost touch with reality have difficulty at this step. The rationale for making the decision isn't based on reality. It is based on a false set of assumptions, or it's based on false information or distorted information. So you can meet all three of those standards above, but if the decision that you arrive at isn't based on real information, you don't have the capability of making this decision. So I'm moving back to our model again. So we've compared an individual's cognitive ability, the specific task ability, and in this case, sexuality. We're not really going to examine their abilities, but we have to consider it, and the context involved in the sexual situation. We use all of that information, combine it with where they are along this continuum: choice, understanding, appreciation, and reason. And at the end of all of that, you can determine, or the clinician can determine, whether or not this individual has capacity to make this decision. This is very important. An individual is always presumed to be capable to make a decision until proven otherwise. the burden is on us to prove that an individual does not have the capability. Now, ostensibly, there are going to be significant differences between the capabilities of a person with mild dementia and somebody with advanced or final stage dementia. So we need to make sure that we're going back to our person-centered approach and not adopting a singular approach to sexuality and dementia. And that's why we have to be careful in terms of policy and practice and consider where this individual is along the continuum of capacity. So we need to talk about how we can gauge an individual's level of ability to participate in these decisions, in these sexual behaviors. And one of the things in doing that, we want to be able to observe the resident in their interactions with others. Sometimes verbal ability, verbal expressive ability is compromised in dementia. So we want to make sure we're focusing on things like body language and facial expression. We want to make sure that we monitor how they're relating to others. Are they able to express themselves? Are they able to receive relevant information? It's not often hard to tell when somebody has a strong reaction to another person advancing upon them. And we want to make sure that we're paying very, very close attention when two people seem to be getting close, are both in that exact same place in terms of being able to give the impression it's a positive thing. And again, as Courtney was saying before, it's not just about sex. It's about intimacy. It's about relationships. So we want to be very, very vigilant about people in the environment and how they're reacting to one another. We also want to consider in terms of dementia, are each of the individuals involved in this situation aware of the identity of the other person? You know, is it possible that somebody is mistaking the woman in front of him for his wife? Or is it possible that individuals don't know each other completely? And I have seen that situation in environments where I have worked where each individual thinks the other is somebody else. In that case, neither had capacity, and really there had to be interventions to ensure that these folks were making poor decisions for themselves. But generally speaking, when the potential for exploitation is high, that is when our obligation to intervene is also high. When the potential for exploitation is high, our obligation to intervene is high. When the potential for exploitation is low, and everybody has the capability to do this, then our obligation to intervene goes down. As a matter of fact, the expectation that we will intervene goes down at that point too.
So, in summary, we want to be providing person-centered care that is empathetic and sensitive. And in order to do that, we need to be aware of our own attitudes and beliefs about aging and sexuality and how those are playing into any professional decisions that we make and interactions with people that we are supposed to be caring for. We need to be educating ourselves and our residents as appropriate about the effects of normal aging and illness and medications on sexual expression. Assist residents to adapt to changes in their sexual functioning and maintain their appearance in the manner that they prefer. It's really important that we are providing relationship-centered care as well and encouraging residents to maintain and develop new social relationships that are meaningful and beneficial to their quality of life and well-being. And finally, we want to have policies in our facilities that enable us to work with our residents and their families and our teams to design plans that support our residents' sexual needs.
So we want to thank everybody for listening to our presentation. We have some resources that are on the slide right here, and I think you have access to the slides online. There are some very, very good resources here that we have. I would especially recommend checking out the Hebrew Homes policy on sexual expression. It really is innovative, and it's kind of one of a kind. And consider adopting some of the tenets in that policy for yourselves. The next slide here is just our contact information if you have other questions or if there are points that you wanted to make. But now we're going to turn it back over to Dr. Walliford to field the questions that have been coming in and see what we can do.
Thank you so much, Dr. Heck, and thank you, Courtney, for this thought-provoking and engaging presentation. I know that our attendees found this information useful and applicable to their daily work, and this is your opportunity, everyone, to post your questions, and we're going to jump into some of those in a minute. As Dr. Heck mentioned, these PowerPoints are all available online for you to download, and so for those of you who maybe joined us a little late or you'd like to share them with your colleagues, they are there and available. So thank you for those resources, too. I know folks will want to take the opportunity to review those. So I would like to go ahead and jump into some of the questions that folks have posed early on, and I encourage everyone to continue to post your questions. So one of the first questions here for either of you, so feel free to duke it out in terms of who gets to respond. How do you ensure privacy when so much communication and involvement is required among various team members? Do you have some thoughts about privacy?
I think that's a really good question. And of course, in a long-term care setting where we are responsible for residents' day-to-day care, and we are providing that care based on care plans, and we're working on an interdisciplinary team, communication about our residents and their behaviors and activities and needs is really a requirement of our jobs. So I think the best way I could answer that question, and I encourage Dr. Heck to jump in if he has any other thoughts, is that we need to be mindful about how we're communicating the information. So how much information about a particular sexual behavior is necessary to communicate? Is it relevant to their care or their care plan? And how are we communicating it? That is, we don't want to be sharing information about our residents' sexual behavior in a gossipy way or anything that makes it very exciting news. It needs to be part of their clinical information, part of the information that we share, and we need to share it in a professional manner. The least amount of information that is necessary. And hopefully that makes sense.
Yeah, it does. And I think what I might want to add to that is it's a great point that you make about how we talk about it. I think how we talk about it also reflects our own beliefs and values. And individual staff members who have difficulty talking about sex or are most offended by sexual concepts are likely to discuss sexual behaviors in the least productive way. So generally speaking, I think continuing to have part of the dialogue in terms of trainings and education, including sexual concepts, increases people's comfort level in general in dealing with these issues, and I think increased comfort equals less pathological communication about it when these things become clinical issues.
You know, and actually what you're saying right there connects with one of the other questions that's come in terms of comfort level with communication. And can you say a little bit about, and this is a much bigger issue, so I'm sorry for opening this can of worms, but can you say a little bit about how cultural differences between staff and residents may play a part in people's values about sexual behavior, sexual activity?
Well, it can mean everything, and there can be a cultural divide, and we define culture very broadly. We're not talking about just ethnic culture. We're talking about socioeconomic status. We're talking about regional customs and traditions. We're talking about educational differences. Culture can be defined so broadly, and any of those issues can present cultural divides. And many times you're going to see a culture divide between staff members and the residents, depending on where you work. And in some cultures, sexuality is going to be much more readily accepted. If somebody, for example, if a staff member walks in on a resident who is engaging in masturbatory behavior, there is a cultural component to how that staff member is going to react. And if that point of reaction, that means the world.
Yeah.
If the reaction is shock and disgust and dismay and the slamming of a door, that's going to invoke a reaction in the resident of one type. If the reaction is, oh, excuse me, I'm sorry, I didn't realize you were busy, doors shut behind them and they go about their day and no more mention is made of it, that's going to produce another reaction or lack thereof of the resident. And culture and a person's own history and belief systems and values play into that point of service, that exact situation where that staff member has to make a decision how to react. And I think a lot of this comes down to, what do you do at this spur of the moment? What do you do when there's a call to action? And culture is one of the major streams of influence on what happens when that goes down. Mm-hmm. Did you have anything you want to add to that, Courtney? Okay.
You know, I think that's very well said. I appreciate, you know, both of your thoughts on both of those challenging questions, I think, because you're right, culture is the root of all of that, and culture very broadly defined. And I like how you both approached this recent case that everyone is talking about, because it really raises to the fore that we need more conversation about this so people can feel comfortable in their responses, whether that's knowing what the policy is where they're employed and also being comfortable with their own responses. Okay, something else we're getting multiple questions about, STDs. On the rise in long-term care, on the rise among older adults. How do you handle that? And have you all ever done or seen, participated in or otherwise, education for residents about the increasing STDs among older adults?
Well, I think that's another excellent question. And one of the items on the last slide about the summary slide was educating our residents about their sexuality as part of the person-centered approach. And I have not personally participated in any educational efforts with older adults, but I know that there are some out there. And I think, especially for older women, they are at really much greater risk of sexually transmitted infections or diseases because of lack of education about safe sex. And if they are embarrassed or uncomfortable talking with their physicians or nurses or other care providers about their sexual behavior and sexual activity, they are at risk for contracting a disease and not having it treated. So being able to talk openly about these issues and educate our residents about safe sex and what the risks and consequences are is going to go a long way to preventing contraction of sexually transmitted diseases.
That's very well said. And what I would add to this is what we also know from the research is that gynecological visits tend to fall off in frequency post-menopause, and that is where a lot of new sexually contracted diseases or illnesses are caught. And I think it's also significant to consider that the fastest rising group of new HIV contractions are women over age 50. So that underscores the need, exactly what you're talking about, Dr. Walliford, about this individual's question that they raised about sexually transmitted infections and the possibility. And that possibility is very real. That possibility is out there. 30 years ago, it may not have occurred to any of us that we were going to have to talk to older adults about using condoms or having tests for sexually transmitted infections. But times have changed. We have to be willing to talk about that, or else there are going to be a number of serious consequences come down the pike if we keep our heads in the sand.
Okay, well, speaking of keeping our heads in the sand, we've had somebody who has both made a comment and posed a question. I want to make the comment because I think that this is a very important thing. You know, in the field of aging, we are currently and have for a long time been wrestling with the language that we use. And I'm grateful that you brought up the both person-centered care approach and also, Courtney, the relationship-centered care and how appropriate, how necessary that is. But the comment here is about the use of the phrase inappropriate sexual behavior. Now, earlier in the presentation, you talked about this is communication, this is normal, this is natural behavior, but then later on talking about inappropriate sexual behavior. Do you have thoughts about how we can reform our language to make other people know that really this is a normal part of personal expression and move away from words like inappropriate sexual behavior?
Yeah, I think there does exist. It's a great point, first of all. It's a very, very great point, and we don't want to over-stigmatize behavior because the person who posed the question is correct. It is a form of expression. But I think what we would add to that is that there is a line. There's always a line in terms of behavior. There's always a line in terms of what society can tolerate. And there's always a line where one person's rights end and another's begins. Mm-hmm. So to reform our language is probably always going to be an ongoing endeavor. But I would make the argument that there is a certain type or degree or severity of behavior that can and should be considered inappropriate for whatever situation that it is in. Mm-hmm. That is not to say it's wrong. I think we need to steer away from language that implies some sort of moral judgment. Absolutely, we should. Inappropriate, I think, implies a lack of fit between the circumstance and the behavior. And if there are better words for that, I would be willing to use those. I think inappropriate has just kind of been the norm. And when we in mental health we like to use words like inappropriate. So if there are more suggestions for better words than that, we're open to it.
Excellent. Well, and I think you're right that it is about the setting and about the fit. And again, I know we're all constantly wrestling with the language that we use, and so I appreciate that approach very much, and I know that the person who posed the comment will too. Okay, so the second part of that in terms of language is that, let's see, I want to get down to the actual question. The question was about how sexuality, intimacy and sexuality needs are not included in care planning. Do you think that there's a change on the horizon coming about addressing, especially in terms of, as you mentioned, Courtney, relationship-centered care?
Well, I would really hope that a change is coming. And I think as we all become more familiar with this issue, with the age wave and the baby boom generation that are aging and entering long-term care, I think sexual expression is going to become more prevalent, and long-term care staff are going to need to be familiar with how to deal with it. So because of that, I would hope that it would become more common to address these needs in the care plan. Mm-hmm. I hope that answers the question.
Yes, and I think that educational offerings like the one that you two have so thought-provokingly and eloquently provided today really helps us to think about this in new ways and have a much broader approach and a much more balanced approach to the content. And hopefully we will all go forth with more knowledge and not such emotional responses to the things maybe that we see in the media, but a more educated response. Mm-hmm. Well, and I'm sorry we haven't been able to get to everyone's questions. Sometimes that does happen, and we will make an attempt to respond to those individually after the fact. Are there things that you, either of you, our presenters, would like to say in closing?
I think the only thing that I would like to add is that I do hope one day a trial like the trial we discussed at the beginning of the presentation doesn't make news. I think the fact that it made news shows how titillating and shocking this issue still is to the public in general. So maybe that could be a good gauge of where we are with older adult sexuality, is when something like this does not make news.
Thank you. Well said. Well said. So once again, thank you, Dr. Heck and Courtney Petley, for your presentation today. You've given us a lot to think about. I'm grateful for that. And also to our supporters. Again, this event is made possible through a grant from the Virginia Center on Aging's Geriatric Training Education Initiative and supported by Riverside Center for Excellence in Aging and Lifelong Health, the Virginia Geriatric Mental Health Partnership, VCU's Department of Gerontology, and World Events Forum. Please don't forget to complete your surveys. You see the instructions here posted on the screen. This is how you will receive your certificate of attendance. Remember that all of our webinars are archived for future viewing and sharing. And I hope that you will join us on May 6th for our next session in this series about assessing risk and managing behaviors in persons with dementia. And I hope that you all have gained something today that will help you do what you do a little better. Thank you for joining us. Have a great day.